Greetings to everyone. I'm Laszlo Papp from the QIMP team, Medical University of Vienna, and I'm going to talk about a project which focuses on prostate cancer. The state-of-the-art prostate cancer risk assessment is mainly performed with the help of the so-called D'Amico score, which is composed of the PSA values, clinical stage and biopsy grading. Unfortunately, this process has its drawbacks, namely that it's neither sensitive nor specific enough. What does it mean? It means that if the patient has a suspicion of cancer and it's assumed that this patient is high risk, then we might decide that the patient needs to undergo a full radical prostatectomy removal. And this has a serious impact on the quality of life. Nevertheless, even if a radical prostatectomy had been performed, there is a 20 to 40% chance that the patient will have recurrence in 5 to 10 years. So our aim was to identify whether we can predict patient risk and recurrence with a high accuracy with the help of radiomics and machine learning analysis. In order to conduct our studies, we collected 122 patients from the pre-rapid trial of ours, and we included 70 patients furthermore in our study because these patients had surgery. We wanted to choose these patients because we wanted a very stable ground truth in the form of full mount histopathological slices. Overall, 52 patients were processed with machine learning because this patient had the risk assessment and the biochemical recurrence. We performed the lesion delineation in our PET MRI studies, and each patient had a dual tracer PET MRI as well as T2ADC and parametric MRI images as well. And all of them had the full mount histopathological slices. The delineation was based on the PET MRI, where we identified PET MRI positive lesions, but we labeled all lesions based on the full mount histopathology slices that were already labeled for us. Here you can see statistics about the extracted lesions. We had 122 lesions altogether, and as you can see, we had a wide range of glioma patterns. So we could establish low-high risk as well as malign and benign lesion predictors. And so we did this with the help of radiomics and machine learning, where we extracted highly repeatable features from our PET MRI images, and then we established two predictive models for each lesion, one which predicts low versus high, and another which was predicting malign versus benign status. And then we went ahead and composed the so-called In-vivo D'Amico score. On the left you can see the basic D'Amico score, and in our patients, because we did not have so many, we decided to go for a binary classification where we separate high-risk patients versus low and medium patients. And the same happened in the In-vivo D'Amico score. The only difference was that we excluded the Gleason score and placed the machine learning score instead, which was a composite score coming from our low versus high as well as malign and benign scores. Here you can see the results in a cross-validation environment. We had a 1000-fold Monte Carlo cross-validation where 80% of the cases were used as training and 20 for validation. And you can see that the sensitivity and the accuracy as well as the negative predictive value to predict post-operative risk with our score was higher than the classic D'Amico score, even though we lost a little specificity. In case of biochemical recurrence, however, we had a much better predictive performance. We achieved 100% sensitivity and a much higher specificity than D'Amico score to predict biochemical recurrence. So overall, what we have seen is that it becomes feasible if we use PET MRI in combination with radiomics and machine learning to predict lesion-specific risk scores. And if we then combine these machine learning generated lesion-specific risk scores into a patient risk predictor, then we can in fact establish an In-vivo D'Amico score, which appears to be accurate enough to be considered as a future alternative of the classic D'Amico score, which is invasive because of biopsy sampling. Thank you very much for your time.